Yes, hi everybody. Now I gotta try and figure out how to add my guest.
You don't seem to be broadcasting, Steve.
It just said I'm live.
Not on YouTube.
Let me go back to my channel. This is a pain in the tuchus, I swear.
Now it's showing you live.
Okay, I'm showing live. All right, back to try
Live
and
now.
get. Now, where is my invite thingy? Here it is. Let's see if that works. I sent out 2 invites, so let's see where it goes from there. So anyway, what we're supposed to be doing today is talking about just healthcare in general, costs, things that have pertained to my own situation, and stuff like that, basically. Depending on how long we go, we might get into healthcare woo. I don't know. So I did go and get the link out. So hopefully I'm going to have people's. This is actually part of the GASP project, which is my good old thing for my donation stuff to try and help with my own expenses, and that includes living in general. There's Shar, there's RSC. Let me well, yeah, I don't know the controls very much on this.
Hello.
Hey!
You are live. Hooray.
Yay! Oh my gosh, this is my 3rd time. So from doing the test the other day, I completely forgot how to start this up.
Wait a minute. How do you normally do your streams then?
I use my iPhone for my stream most of the time. Otherwise, I use OBS if I'm gaming, because the camera that I have here on this computer does not work in my art room with the laptop that's in there. The laptop isn't even accepting its own camera, let alone this one. So I still have to use my iPhone for any of my artwork stuff. So, yeah.
I see.
Oh, and that's the wrong button on the YouTube. Well, I will have to go and edit the GASP thing in later in the description. Anyway, as I had said to anybody who is watching or is going to come and watch, we're kind of just talking about healthcare in the United States, and it doesn't have to be limited to human healthcare. It doesn't have to be limited to, you know, we could get into discussing, well, we're just going to see where this whole thing goes. We got 2 hours, so we'll see what happens. But the GASP project, Shar and others have organized to help myself and my husband out. I had surgery October 4th and had to have a lot of internal work done. And so I have a follow-up appointment on the 1st, again, to see how progress is going, but I don't know when I'm returning to work, so I still have my rent. I have to pay full on my insurance premiums right now because I'm not working, so my employer's not going to cover half. I don't have short-term disability. My paid time off is gone. And yeah, it just snowballs. I still have to pay bills with no income coming in. So this has been a really great help this weekend. Everybody's kind of gotten together, and it's been pretty fantastic. So I set a higher goal on the GoFundMe than I really expected, just in case. But there's my insurance deductible alone per year is almost $7,000. So I mean, and my rent is $1,300 a month, and my husband has MS, and there's days that most of the days that he's having trouble walking without any pain. He's at that point where he's not going to be without pain anymore, and so it's really hard for him to work. And so we essentially have no income right now. So this has been absolutely huge for us. And once things straighten out, I intend to return the favor if we have people that further need help. This is going to be kind of an ongoing thing in the Great Debate community and Great Debate gaming, and just with all of us in general. And it's people sticking together and helping each other out, because unfortunately, the state of our health insurance in the United States isn't really about helping people out. Even in the short term, there's not a lot there. So that's kind of what we're going to be talking about tonight a little bit. So, and I have RSC here, and I have been told you are a doctor, correct?
Yeah, that's right.
Okay, what area do you work in, if you don't mind?
Right now, I do hospitalist work in Cleveland, Ohio.
Oh, wow. Yeah, I do pediatric home care with kids on life support and stuff. So, I've done everything in home. I've done TPN, I've done dialysis, both hemo and peritoneal. And I had worked in dialysis for about 5 years, and that was including acutes, going hospital to hospital and in clinic. So, and then background a bit in psych, hospice, home care since I became an RN in '96. And before that, I was a PCA for 5 years, and including a phlebotomist and EKG tech at another hospital. And yeah, so just been in this a long time.
Yeah. Well, I want to thank Shar for setting all this up, and Christina, I'm glad to see you're doing well. I wish there was something more that we could say other than thoughts and prayers type situation. But
yeah,
everyone who's listening can contribute. I know I'm planning to donate today.
Thank you.
Shar, would you be able to post the link in the chat?
Yeah, maybe? I will spam that. I will.
Oh, I forgot about the live chat. Just a second.
I'll keep an eye on it for you too.
Okay.
I can do that. I can check for questions when we get there.
Okay. There.
And just so you know, the reason I kind of felt like I really wanted to help you out is because I had a surgery very similar to yours, but in Canada, and it cost me $0.
Oh, way to brag, Shar.
Yeah, I don't want to brag. I'm just saying that it blows my mind when I consider the cost. Experience. Yeah, it's just unbelievable.
Yeah, I have a friend from Germany that I used to work with at one of the companies I was at for home care, that she came here and she still doesn't understand this. This makes no sense. And she was doing staffing coordination and some billing coordination for the company. And with the pediatric clients, if they were private pay, it was like you're almost getting milked for everything that they've got, Mm-hmm. And she's like, this makes no sense. And then you're paying the insurance premium, and then you have to pay again.
Mm-hmm.
And
so maybe that's a good place for us to start.
Yeah.
So, I mean, as a doctor, actually, there is zero training on insurance and how the whole healthcare system works. So the knowledge that I have actually is not from my medical training.
Yeah.
My mom is an RN. She's a pediatric RN like you. She's worked at Children's in Dallas for like 30 years. And she's also worked in a private clinic as well. So when I was in high school, in my summers, I would go work at the clinic, and they would put me in charge of a lot of their billing. And a lot of the times the billing was back then, I mean, there wasn't the internet. You couldn't email in the doctor's notes and the text and all things like that. Everything was faxed or over the phone. So I spent a lot of time calling different insurance companies, entering in patient ID numbers over the phone and stuff like that. So that's where I got my basics from, how insurance works here in the US. And the lowdown is there's a few different systems. You have the Medicare, Medicaid insurance, which is the government-sponsored insurance. You can only get that if you qualify. So Medicaid is for people with disabilities. If you're permanently disabled or if you're on temporary disability, you get Medicaid. Medicare is for the elderly. Right now, I think the age is 65 and above, but it's going to change within our lifetime. And likely, people your age, Christina, won't be able to access that benefit until probably 72, 75.
Yep.
With the way that it's financially unstable. There are some exceptions. People like who are on dialysis also get Medicare as well, because that's a long-term disability. Once you get put on end-stage renal disease, you're going to need dialysis for the rest of your life, unless you get a kidney transplant.
The only caveat there with the dialysis, and I kind of want to warn this, is I have friends that still work in dialysis, and because of the way they've been doing billing changes through the kidney specialists and stuff like that, is Medicare is making it that you cannot get your dialysis treatments paid for 3 months after you get your diagnosis and have to start. So you're paying for out of pocket for 3 months.
That's correct.
That's $4,000 to $6,000 a week, from what I understand. Of course, I haven't been in dialysis since 2011 or 12.
No, your numbers are spot on. That's why it's very important for people like me who see that these people are trending towards dialysis to get them enrolled in the Medicare early, so that 4 months expires before they actually need their first dialysis session.
Yeah.
And you're right. It can be $5,000 a week for some people. I know there's one patient who's getting daily dialysis because she had sudden kidney failure. Now, there's not going to be a way for her to get that 4 months in, because she just, went from having normal kidneys to needing dialysis, and she'll probably be on it for the rest of her life. She's going to be stuck with, that bill for 4 months because Medicare won't pay it. And unfortunately, in the end, what happens is the hospital eats that cost. That's part of the problem. There's a very cyclical pattern. We tend to allow people health care, but we refuse to pay for it at the same time. So the Medicare Medicaid system is the public section. The government sets their prices on everything. There's a committee or a branch of the government called the CMS, which is the Center for Medicaid and Medicare Services. They run the show when it comes to Medicare dollars. If your hospital wants to accept Medicare, Medicaid patients, they have to meet certain criteria established by multiple commissions that are based in the government and that look at all sorts of aspects of the hospitals. And they have to meet a certain standard. Otherwise, the hospitals won't be allowed to take care of patients for Medicare and Medicaid. Like I said, the Medicare and Medicaid centers, they set the prices for everything, whether it's surgery, doctor's visits, diseases, anything you can think of, they set the price for it. And I think the way they do it is pretty much a fair system. They have what are called DRGs, which is they basically bill the hospital gets to bill for whatever the problem is. So if a person comes in because they have pneumonia, well, they get put in the DRG group of pneumonia, and that's basically reimbursed. They take all the hospital patients from the previous year and say, okay, how much money was spent on average for a patient with pneumonia? And that's how much the hospital gets. Mm-hmm. So it doesn't matter if that person comes in with a very simple pneumonia, where it's you come in, you get seen for a day, you get maybe like a chest x-ray, and then you go home the next day with antibiotics. Or you have a very severe pneumonia that requires you to go to the ICU, and you're there for weeks in the ICU on a ventilator, and then you slowly come off the ventilator. If the hospital doesn't correctly place that patient in the right type of group and just labels them as a pneumonia, they only get that pneumonia reimbursement. And then the government, bills and manages the patients through their insurance that way. That's the most fair system we have right now. And that really incentivizes the hospitals, and not just the hospitals, but the offices and everything, to properly diagnose people. If you miss the diagnosis, you end up eating the cost is the basis for that system.
And it still happens.
And yeah, it still happens. I mean, I can't always predict when someone who comes in with something simple, like maybe high blood pressure, is going to end up having a stroke. Of course, if they end up having the stroke, then we put them in the group for the stroke, and we get the money. The money that is returned to the hospital is based on the average for a stroke case. But you can't predict some things like that. So it generally works out in the end, because you have some patients where it'll cost a little more to take care of, and some will cost a little less. And in the end, if you're running a hospital efficiently, you should be able to make money. And there are things like bonuses for keeping people out of the hospital, for making sure people go home with the medications they need, for meeting the standards that Medicare and Medicaid set up. So there's ways for hospitals to earn extra money on top of the basics just to cover their cost. But it is very difficult. A lot of hospitals don't meet that. I would probably say 60 to 70% of hospitals run in the red annually because of things where patients get billed for, like the dialysis, where Medicare and Medicaid, they have limits. They won't cover certain things, but the patient needs it, so the patient gets it.
Yeah, it's like my own surgery. I was supposed to be outpatient, and I ended up having to stay overnight and most of the next day because of complications on my recovery part. And, you know, that happens. So,
and it's a one lump sum payment
for outpatient when they can.
Yeah, and that's why they like to push patients out the door immediately. But I also think it's much better if it's a surgery that you can recover from at home. You are better off at home because you're more comfortable, that you're not going to catch the bug that your roommate has or someone else in the hospital has. You're less likely to fall and have those kind of complications. I prefer to see patients at home. They're more comfortable that way.
Yeah.
But if they're not able to go home, they can't eat and drink and you know, and carry about their own bodily functions and take care of themselves, then they need to stay in the hospital. No questions asked.
Yeah.
So Shar, did you have any questions about Medicare, Medicaid? I know that was real brief, but that's the government sponsored. That would be the most akin to what you have in Canada. It's not a single payer system, obviously.
Right. So no, actually, so my question would be, like, how many people never pay their medical bills? And then how much does that impact the hospitals and the healthcare workers? Where does the money go? Like, the money gets charged. Is it just always in debt at that point, or what happens?
So the only place where you can't be denied service is the emergency room. If you come to emergency room, you have to be seen, whether you have insurance or not. So this is kind of a separate subject from the Medicare, Medicaid, but I'm happy to kind of address it. People will come to the emergency room for whatever problem. They fell, they broke their arm, they don't have any insurance. Well, the emergency room is going to manage them, you know, do what they can to treat the pain. If they need to set the bone, they're going to set the bone. They're going to do the x-rays. They will bill the patient if they don't have insurance. But of course, they don't have to pay there and then immediately. The bill gets sent to their home. So one of the ways people dodge these bills is they come in with fake names, fake IDs. That's a little more difficult to get away with now because everything's so automated. Your ID gets established like when you come in the door, so we know who you are and that we're not getting false information. The other thing people do is they give old addresses so that they never can get the bills, receive the bills. And even if they do, no one's going to take away your home because of a medical bill. That doesn't happen for the most part. What happens is if someone doesn't pay the bill for months and months and months, those bills get shuffled onto collection agencies. And basically what collection agencies will say is, oh, I know this person has $10,000 of outstanding medical bills. We'll give you $1,000 and then we'll take over the amount due and try to collect the amount due. But the hospital only gets that $1,000 and then they release the rest to the collection agency, and they can make more money off the patient clearly by collecting the entire amount due if they're able to.
Yeah, I have a few that are in collection, unfortunately. I'm 25 bucking them a month, you know, so.
Yeah, and the bills can be crippling. Once they get switched over to the debt collectors have more recourse in terms of, you know, putting financial penalties on patients. Hospitals can't do that directly.
But then,
even private offices can't do that. But
so, like, in that case, then the hospital's making a lot less money, right?
Yes.
Like, so, like, how are they making do? Like, are they overcharging in the first place?
So that's what happens. It's a little bit of a Robin Hood system. They have to rob from the rich and the people with insurance to pay for the poor who don't have insurance. So the person who comes in that's homeless, that has alcohol intoxication, and they fell and they cracked their head, their care is not going to be paid for because the homeless person has no money. But they're still going to be managed and treated and taken care of in the end. But there's going to be no recompensation for that patient. It falls onto the patients with insurance to be billed more in the minute ways that the hospital can fangle. So some of the things that the hospitals will do is they'll charge patients $100 for meals because the insurance companies are willing to pay $100 for the meal. They'll charge things like $80 for toilet paper because the insurance companies, while a lot of the things they pay for, they set caps on, certain things aren't capped, like toilet paper. So then the hospitals just automatically bill everyone for the max. And that carries over because if you really came in for, $1,000 visit for your stay, you end up getting charged more for those incentives that are used to cover for the people who don't have insurance. So that $1,000 bill might go up to $1,500. And then if your deductible is $5,000 for the year, well, you end up paying that whole $1,500 to your insurance company to cover your care. So that money that's not being used to make sure everybody is insured is really being passed around to everyone who uses that hospital system. So we're paying for their healthcare, whether we want to imagine it or not. It's just that the hospitals are in the red. The hospitals some of them are borrowing money. They're going in and out of different hands. And you may have seen that some of them have been charged with devious practices of billing for fake patients and stuff like that to keep their bottom line and keep the doors open. So, I mean, it's a tough position to be in.
And so, okay, and then so with Medicare and Medicaid, I actually don't know the difference between Medicare and Medicaid. Are they more or less the same?
Medicaid is for disability.
Okay.
You can have short-term disability, like you get injured and it's expected it's going to take you a year to recover, or you have a stroke and it's going to be a while before you recover. You can get on disability through Medicaid, through the government, and they'll cover they'll be your medical insurer for that time. And it can be temporary insurance, or it could be lifelong insurance for someone who, let's say, is born blind. They'll be on permanent disability for the rest of their life because they're born blind. Someone who gets dialysis gets put on Medicare also, because that's a disability that stays with them for the rest of their life and needs to be paid for.
Gotcha.
Medicare covers the elderly, and in some cases it covers the impoverished, like single mothers who have no money and are homeless, and their children in some instances as well. But it's mainly for the elderly.
With medical needs too, that are permanent medical needs. I've seen with Medicare as well.
Correct. There's a lot of overlap with Medicare, but 80% of its budget goes to covering elderly, and right now I think that's 66 and above.
Okay, and so we've got a couple questions in the chat from Dragnaut. He says he'd like you to explain HMOs, and he wants to know how the ACA impacted healthcare.
So,
and also what TRICARE is.
Okay.
Well, that's the thing.
Those are all good questions. So we covered the government-sponsored healthcare systems. So the other two big players in non-government insurance in the U.S. are private insurance, which would be like your Aetnas, your Blue Cross Blue Shield, those kind of companies where you buy an insurance plan, almost like you buy an insurance plan for your vehicle that covers your health care. Or you have what's called an HMO, and that's a management group where you have a large chunk of people who pay into this organization. This organization basically regulates the healthcare expenses for everybody. So if you use more than what you're paying in, well, then you end up paying more. Or if you're not using all your resources, that's too bad. They stay in the pool. So they encourage everyone to use all their medical dollars each year. Those are the differences. Does that make sense?
Yeah.
I think
HMO is kind of like I don't know what you call it, but like a potluck where you throw in money every month
Well, it's like a co-op.
In case you have a big a co-op for health insurance, basically.
Okay.
The private insurers, they basically do the same thing that Medicaid and Medicare do. They negotiate with basically individual hospitals or health networks, and they establish prices. So like your surgery that you had, Christina, the price for it was set as a lump sum by your insurance provider.
Yes.
And I said, this is what we will pay for everything that is included in that care before the hospital, in the hospital, and everything that occurs after the hospital, whether that includes complications or not. And that incentivizes the hospital to do a good job and prevent complications so they can basically break even.
Yeah, because I know in the past, like 15 years, when I had been in the hospitals and stuff, some of the scuttlebutt that was going around is that they were trying to make the hospitals more liable or more aware of complications that were occurring in the hospital. You know, a patient would come in, and the old joke is you don't go to the hospital to get rest or get healthy, you get sick there. And that was happening quite a bit for a while. You know, patients would end up going home with pneumonia, and they were just fine when they went in for a surgery or a broken bone and had to stay overnight, you know, things like that. So there's been a lot of crackdown on that as well to make sure that patients don't get in hospital infections and have more complications than they should have in the first place. So
we have to track that. In one of the hospitals I work at, I'm on the infection committee. So we track that every 3 months. We see the numbers for every type of infection that happens in the hospital, not the ones that come in, but the ones that occur under our watch. So that way we can say, okay, here's where this came from. If there's something we can do to prevent them, we do that immediately, because if we don't meet the regulations that Medicare, Medicaid set, we get penalized. We lose money in the end. And we're talking about millions of dollars. So it's a lot of money for a hospital.
yeah.
So you covered Medicare and Medicaid. What is TRICARE?
So TRICARE it's like a combination of a couple of the systems. So TRICARE, you can have multiple insurances. You can have private insurance, you can have an HMO, and you could have Medicare or Medicaid. And they'll triage them one over the other. So usually if you have a private insurer, the private insurer will be the first one that gets billed. And whatever they set to pay for your medical expenses, they pay. And then if you have a deductible, that deductible falls onto the next insurer, which could be your HMO. And then if there's anything beyond what the HMO is willing to cover, that would fall to your Medicaid or Medicare if you had all three. So you can have multiple insurers, but people aren't willing to pay for multiple insurers. Most people just stick to one. But then you have the supplemental programs you can buy into for like drugs and other things. And there's a lot of supplemental programs that Humana and Aetna and private insurers will offer to people who are on Medicare and Medicaid to cover for their medical costs for medicines and things like that. So it's a very complicated structure that we could talk about for hours. But the basis is it's like a menu. You can order your individualized plan for your healthcare money. Right.
I mean, the closest I get to that is if when I travel, I get travel insurance, but my Alberta healthcare covers some. I went to Spain and I got a really bad sinus infection and needed to see a doctor and get antibiotics. Right. Mm-hmm. It was really great. It was a private. I went to a private clinic, and my Alberta healthcare covered, I don't know, like half or 60% of the cost. And then my travel insurance picked up whatever was left over, and it didn't cost me anything. But I think the visit was originally around $200 Canadian. Like after I converted it, that was the entire cost of my visit to the doctor and my drugs, but it was all covered. So it was kind of an interesting experience because it was out of country.
That's a benefit we don't enjoy.
Yeah. Okay. Gotcha.
Christina, do you want to add something?
Well, I was just thinking, we have another question from Drag that was in that same circle is how did the AMC good grief, the ACA impact our healthcare system? So
the ACA does. No, I don't suffer from enuresis. Thanks for asking, though. The ACA is more commonly called the Obamacare Act. It set a lot of different legislative acts into effect at the same time. The biggest impacts on healthcare were to education. It changed how money was allotted for nursing, medical, PA, I mean, whatever type of education that's related to healthcare. It changed how that money was spent, first of all. Second of all, it started this grouping of diagnoses so that it's one a lot payment. So like for your surgery is one sum payment that goes to the hospital. If you go to the office to be treated for something like
oh, sorry, I lagged out there, guys. I really apologize.
That's all right. I'll start over. So the Affordable Care Act, it was very broad-based. It hit a lot of different things all at the same time. First, it changed education, like healthcare education for nurses, doctors, PAs, everyone, nurse practitioners. It changed how the dollars are offered through the government. Second, it changed how the allotment of money was to be done by Medicare and Medicaid. So it didn't mandate that the insurance companies do anything different in their practices, but for the most part, they mimic what Medicare and Medicaid do 85, 90% of the time. So now when you go to the office for influenza, the doctor diagnoses you with influenza, there's one set amount of money that goes and pays for the whole visit. If you go to the hospital for something, like let's say you have a heart attack, well, there's one lump sum that goes for all heart attacks that are covered by Medicare and Medicaid, and that's kind of what the ACA started out. The big thing that it did for insurance companies is it offered them a conservative means of offering more insurance to a broader base of customers. States now have insurance groups that citizens within those states can buy into. Normally, insurance before the Affordable Care Act, you got your insurance through your primary employer, and they used their employees to form a big pool. And a big pool of people buying health insurance at the same time have better purchasing power, so they can get a better deal in terms of how much will be covered, whether they get 20, 30% coverage for their medical bills, or whatever structure they want. I mean, you could negotiate any kind of structure for your insurance, but you get a better deal the more people you have signing up for insurance with you at the same time. If you just wanted to buy insurance on your own before the Affordable Care Act, you weren't going to get a very good deal. You would be paying a pretty high price for very basic coverage. So by lumping the people in the states who weren't necessarily getting insurance through their employers, it gave people some more options. At the same time, they mandated standards for insurance companies. Insurance companies couldn't give some bare bone policy where you pay $80 a month and you have virtually no benefits other than you can be admitted to hospitals and you can be managed by doctors who accept the insurance, but you pay the bills almost 80, 90% of the bill on your own. That type of insurance was baloney anyways. It was just a way for insurances to sign people up and collect a monthly income from suckers who weren't using the healthcare in general. So they mandated standards, and people who are on those kind of insurances, yeah, they're paying more, but now they actually get services in return. And I think that's where a lot of the complaints came from. Those people like, oh, I've never used the doctor. I had cheap insurance before that didn't really afford me any benefit, but now I have to pay 3 or 4 times as much. I'm not happy with that. But now they actually have a net underneath them should something happen. So that increased the pool of people who had legitimate insurance that would actually take care of them should they need it. The second thing it did is it provided more access to people who are uninsured. I was uninsured before the Affordable Care Act. I couldn't get insurance through any employers or anything because I was in medical school, and the type of insurance that was offered through my medical school was one of those bottom basement insurance plans that didn't cover anything, but you had to pay like $80 a month or something for it. Yeah. So once that insurance policy was canceled, I at least was able to get something through one of the state-sponsored programs.
Yeah, and I remember when
lowered the uninsured pool.
I remember when the ACA came in, and part of the big uproar too was that, and there still really isn't a lot of control on what the insurance companies can charge for the monthly premiums. So what I fell into, I had really crappy insurance before that, and then the Minnesota insurance thing came up, MNsure did, and I found a really good one that covered quite a bit, and it was cheap, and so I got it. And then that company turned around, held on to my checks, and didn't cash them, and then claimed I didn't pay and canceled me, and then I couldn't get any more insurance. Well, I wasn't the only one, and it was on our local PBS and everything else that this company was getting a massive lawsuit, and because they found out they were not making a profit.
Mm-hmm.
And so they had started out too low under the ACA mandates, and they weren't making money, so they tried to do all this stinky stuff just to get rid of people or force them to pay more. And they trapped us into where we couldn't get insurance for a while. And fortunately, the people won the case against the insurance company, and I was able to get insurance after that. But it's not like it was in the 90s when I was working in the hospital and I had free insurance as long as I went for treatment in that certain health system that I was working in, which was fantastic when I was in RN school. I didn't have to pay for anything. But I miss that. I really, really do. But it's so out of control now. I don't even know how we begin to even fix some of these costs. I mean, the ACA was a start. But what people don't realize is that it was a start. There's still a lot more that needs to be repaired in the billing and in the costs of healthcare in general.
Correct. I mean, and I haven't even touched on 95% of what the ACA did. It initially set standards that everyone had to buy a health insurance. There was a mandate, and there was supposed to be a penalty if you didn't get health insurance within X number of years. That was rejected by the Supreme Court as unconstitutional, so there is no penalty. There still is a mandate, but as far as I'm aware, there's no penalty if you don't get the health insurance.
Yeah.
And of course, the biggest thing that it did that benefited patients was it banned insurance companies from charging people more for pre-existing conditions, and it didn't allow them to drop people for pre-existing conditions. Before the Affordable Care Act, health insurance policies were able to establish maximums on how much health insurance you could obtain through them. And most of them said if you use more than $1 million of healthcare dollars while under our plan, we have the right to basically boot you off the plan the minute you spent that $1 millionth dollar. And you can just imagine the types of people who have had serious problems, major car accidents, needing severe brain injury, surgeries, things like that. They can go through $1 million in just your recovery cost. That doesn't even cover, the time that they need to follow up afterwards with physical therapy or home care or things like that. They can run through that money in an instant, and then before you know it, they're denied coverage across the board. Insurance companies can no longer do that. But because that avenue was blocked, they came up with sneaky things like what Christina was talking about, where they'll hold your payments and then claim you don't pay.
Yeah.
And then because you didn't pay, if you don't pay, they have the right to drop you from their policy. But they did that to target people that they knew wouldn't be cash cows for them. Some people they're going to make money on, some people they're going to spend more money on. That's just how insurance works. Yeah,
I remember back in the day when I had just become an RN and I started working at a nursing home, and a couple months later after I started and I got the insurance active, I was pregnant. And so the insurance company tried to say that was a pre-existing condition. I was only like 2 months pregnant on top of it. I'm like, how long do you guys think I was actually pregnant? And they weren't able to continue with that one, fortunately. But then with my son, the insurance company tried to deny that he was born, that he existed, even though there was a Social Security number, and the hospital was billing for his ICU stay for 5 days and stuff like that. I mean, the hospital and Social Security said, yeah, there's a baby here. And the insurance company's like, no, there isn't. And round and round and round it went again in court. And finally, an insurance company had to pay up.
Mm-hmm. And the thing is, it's so much cheaper for the insurance company to take you to court because they know you don't have a lawyer, and they know they have lawyers on staff, and they can get the lawyers to save them millions of dollars by basically pushing off people's cases to the point where some of them die. And once they die, They can just say, okay, well, no, the hospital failed them, so we're not going to pay anything. And that's obviously not right.
Yeah. There is a question from Dragnot that he wants Char to read aloud.
Yeah. So, and I can only assume that this is a very serious question, that Dragnot needs some over the internet diagnosis here. He wants you to explain what causes involuntary priapism and how would one detect it?
That question is beyond my training, unfortunately. For that.
I'm just an RN, sorry. Okay, what else did we have here? Yeah, Medicare would be the primary insurance. Most people also have secondary insurance. I have some clients that have 3 insurances active at the same time. Let's see. Oh, yeah, he's going through his EMT training and stated that my training dummy had a priapism. Oh, my word. Let's see.
Okay, did I answer all of Drag's questions finally?
I'm looking. I'm trying to see.
I think so. If you guys have more questions, post them.
So, I know Char actually gave me some questions she had about the healthcare system here in the U.S., and I just kind of wanted to go through some of them because I think most people would find these answers interesting. The first question she asked was, how much does a typical doctor's visit cost? So this is assuming you're going to someone's office. And the answer is it varies greatly across the country. In some parts of the country, it can be as low as $75, $60. In other places, it can be as high as $400 to $500. It's depending on who you're seeing and what's the reason. The doctors now, with the Affordable Care Act, the way that we bill it's based on your diagnosis and how much time we are involved in your case. So the first part is your diagnosis, and obviously the more severe the diagnosis, the higher the level of your billing code. And there are 3 levels. There's basically like a low level, a moderate level, and a high level. And the high level is supposed to correspond to about a 40-minute office visit. Not necessarily 40 minutes of talking to the doctor, but 40 minutes of the doctor working on either paperwork for you, prescriptions for you, getting services lined up for you. I mean, something related to the patient, including the visit and the interview, the examination of the patient. And then there's like a moderate visit's like 25 to 30 minutes, and a low-level visit is like 15 and under. And there's different, based on the code and the diagnosis of the patient, tells the insurance company how much they have to pay for that visit. And then, of course, the doctor decides to charge more than that, that bill goes to the patient. But that's usually just a waste of money because patients don't pay those kind of bills for the most part. Some people will pay them, though. But it really depends on the doctor. Most doctors will just accept whatever the insurance pays. If you're not going to use insurance, they'll say, okay, this is the flat fee. I'll charge you $50 for today's visit, or $100 if it's more severe. And that can be arranged with physicians as well. I mean, physicians working in offices, basically, if they have their own practice, they're their own boss. They can charge whatever they want. They can charge you a chicken and a pig if they wanted to, because it's their business. But if they're working in an office under a corporate umbrella, then there's limitations. They probably don't have as much flexibility. They can only accept the dollars that are set by their corporate structure.
Okay, and we also had a question from Vincent Jones about the basics of HIPAA, the Privacy Act, for people who don't understand what HIPAA is.
Do you want to take that one, actually, Christina?
Yeah.
Very familiar.
Yeah, because that's something that I deal with more. What it is that your personal information, this includes your diagnoses when you go in for any treatment, your financial information, your name, anything else, your caregivers, the staff that are involved with your care, and this goes for home care, this goes for hospital, this goes for clinic. We can only discuss your information with people directly involved with caring for you. If you have certain family members that you want information shared with, that's usually done determine when you come in and the paperwork's filled out and who do you want as an emergency contact, that type of thing. And you can specify who you do not want the staff talking to, if there's certain family members and stuff. If these things are violated by your staff members, like if they share your personal information or photos of you or anything like that on social media, or leak it out to friends in a restaurant, anything like that, you have recourse to sue them, because and it will cost them fines. It'll cost them their jobs. There's oftentimes jail time. It can ruin careers if somebody lets things slip. And that's why when, like I know RSC has done it, Dragnot has done it. I've said the same thing when certain people ask, well, can we have case studies, or can you give us personal information about patients who've had cancer or had this or had that? We cannot, because it'll cost us everything. This HIPAA is a privacy act that protects the patient's privacy and the patient's rights. And I hope I explained that clear enough.
I thought that was a great explanation, Christina. That doesn't mean we can't discuss cases, though. We could discuss cases where we don't identify the patient.
Yeah.
So if we don't give you any information about the patient other than like the facts of why they're there, what we see wrong with them, what we're planning to do, you don't know who we're talking about. And that's discussed regularly amongst employees and communicated to other members outside the hospital, whether it's pharmacy staff, whether that's someone who's setting up a patient to get like a wheelchair at home. That kind of information can be exchanged rather freely, because we're not violating the HIPAA. We're not identifying their address, their phone number, their date of birth, and those kind of protected information.
Tommy Hall has brought up, he said our healthcare costs went up from about $500 a month to over $1,200 a month under Obama. What's your opinion on that?
Well, I mean, I don't know the exact details of your previous plan, Tommy. I do know that the ACA set up minimums on what health insurance had to offer. They have to offer preventative care now. There were policies that wouldn't offer you free flu shots, wouldn't offer to reimburse patients or providers for visits for vaccinations, for visits like an annual checkup. That is all mandated now. They have to pay the physician for that. You aren't required to pay for those things anymore, because they want more people to get access to that, because it saves the health industry and healthcare dollars of the whole country overall. The more people get vaccinated, the more people go for the regular checkups, because that way things can be tackled before they become so serious they require a lengthy hospital stay. And it's just better for you overall to not have to be in the hospital for a long time. Additionally, health insurance policies didn't cover very much previously. I told everyone about my insurance plan that I had when I was in medical school, of all things. It didn't even cover 5% of your medical bill. So if you actually had medical bills from, let's say, something like, we were in the Caribbean, say I came down with like dengue fever and I was sick for a month and I had to be in the hospital for 2 weeks, I would have had to pay 95% of that. The insurance company would have paid 5%. That's nothing. That plan was worthless. It wasn't even worth the paper I signed to get the policy. Health insurance companies need to cover a substantial amount of the healthcare costs for their patients. Otherwise, they're worthless. Otherwise, the patient is paying for everything. I think we can all agree on that. And because those minimums were raised, unfortunately, those cheap plans basically went away because they're illegal. I can't pay $80 a month for health insurance, because there's no insurance company that's going to be able to afford to give people both the minimum coverage of annual checkups, vaccines, and all those kind of things, on top of making sure they pay for a significant portion of any hospital visit, any serious incident, any doctor's visit. It just wouldn't be financially viable for them. So they had to raise their prices. I think that's probably what you're experiencing, Tommy. I mean, I don't know. You're saying you have a family of 5? $1,200 isn't too much for a family of 5, I would say. I mean, that's what, less than $300 a month for everybody? And hopefully you're getting all the things that you need for your kids, your wife. She gets her, female visits also included as part of that. And should anything happen to any of you, the substantial amount of that money will be paid for by the insurance, and you will not hit your pocketbook in the end. Because we don't want people to go bankrupt for the health care they need.
Yeah, I think what Tommy might be running into is Drag said that he looked it up, and Texas was one of the 19 states that sabotaged their own insurance market once, in the wake of ACA being implemented. And the other problem that Tommy seems to have is that he's self-employed. My best friend, they own a company, and she can't get disability, and their insurance costs are extremely high unless they sell the company that the family owns. And that's not an issue in healthcare itself. That is an issue with the laws that are in place that should be putting a cap on how much control an insurance company has over what they want to pay for and what they want to charge you. That's not an ACA thing at that point. That's state by state. That is county by county, and that is a local and a company billing situation at that point. Like I said, my best friend, she can't even get disability right now unless they sell their business, and she needs disability.
And the thing is, there are a lot of states like Texas where because of the politics of how it looked, people decided not to invest money into the insurance market to make sure people had a good knowledge of the choices they had. And there were also, the government was planning to subsidize these new policies to cover the change. This was a big change for the insurance companies to cover. So the government was willing to foot the bill for some of it while the insurance companies adapted, while new enrollees got on. But some states decided to decline that coverage for the members of their state, which, why would you turn away free money? Well, there are political reasons for that.
Yeah, and my husband brought up, he's Tezcat Lapoca 29, by the way. With our situation, what happened there is I do get insurance through my employer. And like I said, right now that I'm not working and I'm in my recovery time, I have to pay the full amount. But I'm paying between their reimbursement and what I pay is almost $500 a month on my insurance normally. That's just me. I can't get him on the plan because that adds another $900 a month on top of what I'm paying for myself to get him on my insurance plan. Now, luckily, he's got insurance through Lyft right now because he drives for Lyft when he's able to drive. And, that's helped out quite a bit. And he's only getting his treatment for MS through a study through the University of Minnesota. That's the only reason why he's getting any medications at this point at all. Because it's so expensive to add a family on there, or even one family member on there. There's greater discounts if you're adding more family members. But both of my children are adults and they've got their own insurance and they're living on their own. So I have no other recourse, which is why just adding him costs me more than if I had 2 younger kids and could add him and the kids. And so it's still really messed up.
Another thing the ACA changed that I didn't even mention, it raised the age limits. You could keep kids on family plans until 26. It used to be, I think, at 21 or maybe even 18 that kids could no longer stay on family insurance plans and had to purchase their own insurance.
Yeah. And Dragnot brought up a good point, that he remembers that someone back during the initial rollout of the ACA, that the person had nothing but disdain about the whole thing, but they never looked into whether the involvement of the state that they lived in how the ACA was going to be enacted. So there's a whole lot of issues there. It's not Obama's fault. It's not any one person's fault. It's the government and it's the insurance companies. And unfortunately, it's also the healthcare industry. I hate those words together, but it's the truth.
Yeah. It's the truth. You know, the Affordable Care Act actually made insurance markets a ton of money by enrolling millions of people that weren't able to access insurance before. I mean, I don't think they're crying for money. They have made record profits over the last 4 to 5 years. If this was a failing system, they would all be out of business. They're actually doing the best they've ever done.
Yeah.
But the problem is, while Obamacare made it a little easier for patients and patient advocates to fight when insurance companies do cruel things like what they did to you in terms of denying you service with that billing fiasco, there's always going to be end arounds whenever you make any kind of law or regulation. And you have to keep on top of it, unfortunately, because every time you close loophole A, you open up loophole C and D.
And I used to work I used to work in group homes for years as well, so I dealt with a lot of elderly patients. And it is not a myth, it's not fake stories, anything like that. I dealt with a lot of patients who had to choose between diabetes medication and food. They had to choose between their heart medication and food. And this was before the ACA came into effect. I'm not seeing that much of that now. The costs are still high up there, especially if you have somebody who needs long-term care. But it's not like it was. The insurance companies do pay a lot more. But yeah, people were dying of complications from their illnesses because they had to choose, okay, do I eat today or do I take my pills? Or do I even buy my pills? And since I have the health insurance, I have some medications I don't pay for at all. And I'm very happy for that because I've got high blood pressure and diabetes and, I need these medications, but I don't, because my insurance costs come out of my paycheck, I don't have to look at it. And it's not as expensive for me now. I mean, yeah, my copay is very high or my yearly deductible is high. But month to month, it's not as high for me now as it was 6 years ago. And my company's kept the new contract now for the last 3 years. So I can actually afford to take care of my bills and take care of my medications and any other care that I need, except at this point where I have no income. So the ACA did a lot of good in a lot of respects, but it's not perfect. There needs to be more done.
Yeah, and I can think of one thing right off the bat. Right now, with private and the government insurance through the ACA, the markets, you can only sign up during certain windows of the year. So let's say you lose your insurance in January. Well, I think the next market that you can sign up for is like in May. So you have to wait 4 or 5 months before you could even sign up for another insurance once your employer either, loses their coverage or something like that. So it could be people can lose insurance for a myriad of reasons, and there's no recourse for them to instantly get on something else immediately.
Well, and the thing that we're facing right now is when I do work, I mean, I do make a decent amount of money. I'm still paying student loans and things like that, but I'm as an RN and a specialized RN, I do make some decent money. And what we're afraid of is my husband's going to have to file for a disability at some point. And I don't know if he's going to be able to get it because I make too much money. And so the problem here again is there's so many more factors other than just the insurance companies. And I know it sounds like I'm giving the insurance companies an excuse, but you also have, again, it falls down to the local and state governments and then any federal governments or subsidies that are funding the states. And round it goes. This is a big beast in the United States. And we're only looking at one little hair on its leg right now. And I don't know how we can go about even trying to fix this.
I mean, we have said a lot of things about how the insurance companies have shortchanged people and they've done this and that and they're making record profits. But in all honesty, in my opinion, and this might not be a very popular opinion, The reason that healthcare cost is so high in this country is because of doctors. Doctors order more tests. They provide more medications and more treatments to patients that are likely unnecessary in some instances. There are some patients who get medications that they don't need for decades. Should that person have spent all that money on it? Well, it's too late now, but some doctor saw that an insurance company would pay for it, so they decided to give it to them and use that benefit. So, I mean, it's like a chicken and the egg scenario. Who started the problem? Did the insurance start the problem by offering to cover for this? And then doctors have said, okay, well, they're covering for this. I should give this to my patients. I don't know. I think it's the doctor's fault. We should only be giving patients the things they need that will clearly and demonstrably benefit them overall. A lot of patients get unnecessary testing. A lot of people, even in the hospitals I work at, they get blood drawn every day. They don't need blood draws every day. They don't need certain things done for them if they're not having problems, but they get them most of the time because doctors are there's a lot of covering your own ass when you're in the hospital. You don't want to miss something, not because you didn't do a good job managing the patient or examining the patient, but just because there's that blue herring once in a while, you're taking care of someone and all of a sudden they have a heart attack where you didn't think there was anything wrong. Well, so now you're just going to order these unnecessary extra tests for all your patients because you want to be certain that they're not going to have the heart attack on you. But that's unnecessary. You shouldn't be doing those things. But I think a lot of doctors get, jaded from the legal process that's behind medicine and the litigious nature of it nowadays. So there's a lot of that going on. And that's the real reason why our costs are so much more expensive than other countries. Yeah. And the other half of that is that we don't cover the basic things. Why aren't we covering all the simple medications that prevent people from coming back to the hospital multiple times? One patient who comes to the hospital more than 5 times in a year should be getting all the medicines that would keep them out of the hospital paid for free for the rest of their life. Every hospital stay is thousands and thousands of dollars. If we could give them the medications and prevent even one of those hospital visits, we have saved money overall for everyone.
Yes, I agree with that. And I hate to say it, that's where I almost agree with Pat Roberts. Because, oh my gosh, I think a church just imploded somewhere. Anyway, he is saying, prevention is key. And when I went into nursing school, we were taught prevention, and teaching the public and teaching your clients and, trying to get people as healthy as possible so that they didn't have to go in as often or go in with these
your husband's scolding you.
Yes. It was like vitamins and nutrition teaching and things like that. And while things like nutrition aren't going to cure all diseases and stuff, it is going to prevent you from going in as often. I mean, if you're, in myself, I let my body go. So I'm obese, and I'm getting the weight down now. But that caused me a lot of problems. And that was a contributing factor to my having a TMI, my uterus sticking out and pulling down my other organs. And I had to go in and have that all raised back up and the thing removed completely. And that's part of why I still have some of the complications I do right now. And some of it was my fault and I knew better, but I didn't have a real incentive to, there was depression and other things going on, but I didn't have this incentive to keep myself as healthy and as active as I was in high school. And there's a lot of people in the community, they have even found some recent study where they said that, and no slam on people who are Black, but there's a certain part of the culture, at least in Minnesota and some other states, where they don't want to eat healthy food because that's a white man thing. And it's like, how do you get past that and get people to take initiative and take control of their own lives and their own healthcare enough to prevent them from going in, which in the long run would lower our healthcare costs?
You're asking the question, Why does the person who needs dialysis but refuses to get dialysis, who always comes to the hospital every week, like, why don't they just get the dialysis? Well, some people aren't ready to face, that reality. I think we just have to wait and help them come to the point where they're ready to face that. Whether it's the person with cancer who's, end stage, who needs to be in a hospice but refuses and wants to stay at home when they really can't make it at home. They keep coming back to the hospital. They need more support that just can't be offered in the comfort of their home. Some people are in a state of denial about their own situation, about the things they need to be doing. I'm not of the mind that I'm here to scold people for not doing the right things. I definitely want to point the right path out for them and help them guide them there. Whether it's, one visit or one hospitalization that gets them on the right path, or multiple, I'm all about getting them in that right direction, regardless of how long it takes. Some of them never get there, though, which is unfortunate.
Yeah, and in my case, like my thyroid has been non-functioning for probably the last 15 years or so. And I had to get on other medications to kind of help boost my energy level and keep my blood work under control, like my cholesterol and things like that. I've only been on Lipitor for like the last 4 months. And once I got on that, combined with the metformin and combined with my thyroid medication and my blood pressure medication, because I'm labile, I'm dangerously labile.
Mm-hmm.
It goes up and down for anybody who doesn't know what that is. Once I got on the doggone Lipitor, I was starting to be able to lose some weight all of a sudden. And it's like just something that had to kind of push my metabolism or push me or something. And it wasn't for lack of working out. It wasn't anything like that. I just was against this wall where I wasn't going anywhere. So I've been holding over 30 pounds off at this point. I still need to lose another 70 or something like that. But
hey, congratulations. That's great that you've
thank
lost
you.
that weight.
But
That's
again, too, it was the stubbornness on the dietary as well, because I love meat and I love bad things. Chips are like my binge thing. I do binge. I have to be very, very careful on what I eat and stuff. And part of it was I had to quit drinking Mountain Dew and things like that. And that took me years. So I understand where these patients are coming from, is that some of these lifestyle changes and these habit changes have to take time in order to break the darn things.
Mm-hmm.
The only problem is that some patients don't have that time.
Exactly.
I'm lucky. I think I've got myself that time, and I actually think I'm rocking 51 pretty well.
That's awesome. I mean, I could tell you personally, my mom and my father are both diabetics. And I mean, now that I'm a doctor, I'm kind of shocked to see the way that my healthcare was managed when I was a kid. My brothers we were all started on statins. Like when I was, I think, 12, I was started on a statin. My brothers were like 9 and 6, and they were started on statins at that young of an age.
Wow.
I would never do that to a child. And I went through all the cholesterol medicines. None of the cholesterol medicines touched my cholesterol as a kid. But now I'm actually, the last time I had my cholesterol checked, they were really good. They balanced out after, puberty and everything. Go figure. So that's just an example of wasted healthcare money. Why were they ordering those tests of cholesterol on a child in the first place? Yeah, I understand my father and mother both have high cholesterol, but kids don't generally have cholesterol problems unless there's some other disease in play.
Yeah.
It didn't apply to me or my brothers, but the doctor that took care of us still ordered all these tests. A lot of them were unnecessary now that I kind of understand the medical field. There was a lot of wasted money there.
Yeah.
And that's happening everywhere. It happens to good doctors. It happens to me. I find myself that once in a while, yes, I realize I go back and say, hey, you know what? I actually didn't need to order this test. But as long as I think people like myself are more aware of minimizing the things we're testing for and not just blanket test one for everything, we can make a better change on people's overall health, because it's not like these tests are benign. These tests come with risk. When you go for a chest x-ray, you're getting radiation equivalent to about 10 months of just, normal radiation on the ground. You get a CT scan, you're getting about 2 or 3 years worth of radiation all at once. You get the injections in the arms. There's a risk associated with those things.
Yeah.
And they're finding more and more long-term effects from that stuff that maybe we can't clarify right now, but we know that we shouldn't use them unless absolutely necessary.
Yeah. And then, unfortunately, that kind of fear of doing too many tests kind of actually hit me 2 weeks before I had to have my surgery. We went out to eat, and we were at this buffet restaurant where the food was really good. The place was nice and clean, everything. And it was almost exactly 24 hours later, I had projectile vomiting and projectile diarrhea, and it wasn't stopping. And so my husband called 911, and somehow the dispatcher got it in their head that I had been drinking. So they had to give me Zofran, which is an anti-nausea medication. They had to do that in the ambulance. I had some bags of IV fluids and stuff. And then what happened then is, here I'm in the ER. It was the EMTs that told me what the dispatcher said. So I get into the ER, and oh, I'm going to have to, just a second. I have to take care of somebody here. Yeah, there we go. Anyway, they went and they said that they gave me more of the Zofran. They gave me Benadryl. I got more IV. And after I'm sleeping for a bit, and they only drew, just the regular blood vials. And by this point I was so out of it, but my brain, I used to be a phlebotomist. And I still, that part of me was still thinking, but I didn't say anything. And so then what happened is the doctor said to me in the ER after I woke back up, I think I froze again.
I can still hear you.
You're okay.
All right. Anyway, the doctor said, yeah, we didn't find any bacterial, so this was just viral stomach. And I'm sitting there and I'm thinking, I didn't see you guys draw any blood cultures, which are specific bottles. So I go, and unfortunately, I'm looking at my chart a few days later, and they drew a metabolic panel for alcohol poisoning and never checked me for food poisoning. And this same hospital I went to had gone and given somebody else anti-nausea medication because they had stomach pain, and 3 days later, that person had their appendix rupture. So it still happens.
Human error is actually, there was a recent study maybe like 4 or 5 months ago that said human error in hospital settings is actually the #1 cause of mortality in the hospital.
Yeah.
It's very serious, so that medical errors lead to negative patient outcomes. And on average, the average documentation, so whoever's doing documents, whether it's a nurse, a doctor, someone else, a student, there's on average 2 to 3 errors in each document. Believe it or not.
Mm-hmm.
Even if you go to Harvard, there's 2 to 3 errors on each document. So just multiply that by the number of documents, and eventually one of them is going to hit a patient and hit them in a way that's devastating. So we really have to be better about making sure we're accurate, we're reflecting what is actually going on, and we're basically double checking our work. That's really what it takes. It takes another 45 seconds of making sure the things that we're documenting are correct. It's the right person, the right condition, the right treatment. And we have to be better at that, because right now I'm guilty of this just like everyone else. We love to do things quickly, rapidly, move on to the next patient, because it's a never-ending cycle. I mean, I remember, I think on Tuesday, I think I got 10 patients in the course of 2 hours. And so a night that I would have normally gone home at like 6 or 7, I was still at the hospital at like 11 o'clock. That many patients in the span of 2 hours, you can't see and manage all of them safely unless you're there for the appropriate amount of time, and you recheck the things you're doing. Am I doing this right? Is this the right person? Because I'm human. I can make errors too.
Yeah.
But I want to make sure I don't make errors. That's the thing.
I watched a lot of ER back in the day. So, you know, I obviously know how things are.
Not accurate.
I know. So I do have another question. One thing, it's kind of a weird thing, but there are Canadians that go to places like Mexico for medical procedures.
Yeah.
Sometimes the reasons Canadians go is because we have sometimes, depending on what you need, longer wait times. So people will, you know, skip the queue and go to Mexico to get for fairly minor things, generally speaking, right? Sometimes a lot of dental care, actually, because our dental is not covered in Canada. So sometimes people go for cheaper dental care. Is that something Americans do?
It is now.
Yeah.
It's, what is it called? There's a term for it when you go overseas or to another country for medical care. I'm blanking on the term, but it's like
I don't know.
It's not important, but we understand the concept. You're going somewhere where it's more affordable, where you can get it done on the time frame that you want. Whereas in Canada, I understand the single payer system is great for covering everyone. It's not great for everyone's schedules, though, and people have busy lives, and sometimes they want their, you know, they want their delivery to happen on the third Wednesday of November, and the healthcare system's like, no, you're going to get in line and you're going to have your delivery just like everyone else. You're going to wait your 40 weeks and then 2 more weeks, and if after then you haven't delivered, we'll schedule you for a C-section. That's how to equally distribute healthcare dollars amongst people when you're all paying in the same pool. I think there should be options for people who don't want to wait in line. If you want to pay extra and get the easy pass to go ahead of everyone else for those kind of things, I think you should be allowed to. If you want to pay the money for it, if you want to reimburse the healthcare system, I'm fine with that. I think everyone has their own opinion of it, though, and because some places aren't offering that kind of a system, they go elsewhere.
Yeah.
I mean, it's anecdotal, but when I was in China, we ended up sort of staying with some people that were also traveling, and they were like a traveling band, and none of them had jobs. None of them had ever had jobs. They just traveled and made money playing on the streets. And one of them got a really severe abscess in his tooth, and he ended up having to get a root canal, and there was a bad infection. It took him 3 dentist visits, and they paid it like just with cash from, like, he's like, oh, we got to go out and play some music to make some money so I can go to the dentist. And after his 3 dentist visits, I think the total was $350 US for 3 dental visits to get like a root canal with an abscess and a bunch of medications, and he had to go back for a cap and all this stuff. And I was like, that's cheap. Right? Like no insurance or anything. I couldn't believe that.
Well, I mean, there's a difference.
Yes, there is, which is
the Chinese medications aren't heavily regulated.
Right.
And in fact, there was a huge recall this week of a medication called valsartan that came from China that FDA refused to allow to be sold in the U.S. because it contained other things. And first of all, it didn't contain the right amount of the product it's designed to be sold for. So if you don't have the right amount of the medication that the person's taking it for, they're not going to get the benefit that they're expecting.
Yeah. Okay. I assume the care, well, I don't really want to get operated on in some countries in the world, let's just say.
Yeah.
but yeah, I mean, I just think I just think costs are inflated. But now that we've had this talk, you've kind of explained why, and that makes a lot of sense.
I mean, that's not the only reason why they're inflated. I mean, the medical insurance companies, they know there's more money, and the medication companies know there's more money here to be made.
Yeah.
They will bill people and basically see how much they can pay. And if patients can't pay and get money managed with their medication, then they start to cave. Say, okay, well, maybe we can offer you a lower price because you're a special case.
Yeah.
Because they want their medication to be given to everybody who's eligible to receive it because it's competitive.
Yeah.
So that's how they roll. They try to bang everybody for the most buck they can get.
Yeah. My other question was, and I just heard this last week, I read that it costs approximately $30,000 to like go through pregnancy and give birth in the US. Does that sound like an accurate amount?
I mean, that does sound pretty close to what it would cost overall.
Yeah.
For all the healthcare visits, because there's usually multiple visits.
Yeah.
At certain weeks along in the pregnancy, and with each of those weeks, there are certain tests that are going to be run, and these include things like testing for HIV. It's not a cheap thing to test for, but we want to prevent the spread of HIV. And the difference between the United States and Africa is that people in Africa don't get tested for HIV when they're pregnant. And that's why they have the outbreak they have there. Most of the transmission occurs from mother to baby. Yeah. And it's very sad to see a child who's born with HIV because they're going to have that for the rest of their life.
Right.
And that's an even higher expense. So by doing that simple HIV test in the office while the child is, in the womb, very early on, the mother can be started on medications that are safe in that part of pregnancy that will reduce the rate of transmission to the baby during delivery.
Right. Okay.
And you're talking about, spending a couple $1,000s now versus spending a lifetime of HIV medication prices. It's a no-brainer. You do the HIV test for all mothers.
Yeah.
Because just catching one HIV patient who you can prevent from passing it to their baby is saving millions of dollars for everybody overall.
Right.
And the more type of medicine we can practice like that we're anticipating the problems and preventing them from being spread or prevent them from becoming so bad that they require huge healthcare dollars in the long run, that's how we'll save healthcare in this country.
Right. And then
it's a different level than a lot of other countries.
And I assume the actual childbirth is not cheap, right? If you're getting that done in a hospital.
I mean, it's more caveated here. I mean, you get private rooms, and you've made it very comfortable, and you get the medications, you get the blocks and things like that. Right. Those are all very good things, in my opinion.
I think I read too that if you have to have a C-section at the last second, that could be an extra $20,000.
I don't think it's that much, actually.
No?
I think when I was doing it, the OB was like, "Yeah, I get like $200 for doing a C-section now." They used to get like $3,000 for doing a C-section back in like the 80s and 90s. But now it's such an easy procedure, and they can do it in less than 30 minutes safely with the support staff around them. They don't get to make that much.
Right.
But yeah, they do it when they need to. Some of them do it a little more unnecessarily for patients who, I want my child to be born on this day. And if you get a C-section, the date the baby's going to be born. So there's a little more tailoring to patients here in the U.S., but I don't think it's a bad thing. And I think that patients who get, the care in hospital, there's a much less risk of adverse events happening to the baby during delivery.
Right.
Whether it's cord around the neck, whether it's, malrotation, whether it's even, fetal demise, because that does happen around pregnancy. Women can have their uterus rupture and things like that. And if that happens, the baby has to be removed immediately or the baby will die. And the mother is still at risk as well. So you're taking care of two patients. It's just better that they're in the hospital at that crucial time to be monitored closely. And if we can save one death, whether it's the mother or the baby, you can't put a price on that.
No, you can't.
Yeah, no, it just blows my mind because, sometimes people are like, well, if you don't want a baby, you can just give it up for adoption. But I think, wow, I mean, there's a lot of steps in between I'm pregnant and adoption, right, to think about. And we don't consider the money sometimes, which is prohibitive in cases.
Yeah.
Yeah.
I mean, we're getting closer and closer to some futuristic dystopia. The first woman to have received a uterus transplant and deliver a child, her child is now 5 years old and very healthy. No medical problems whatsoever. And I believe she had a vaginal delivery as well.
Wow.
You can imagine that maybe in the future,
it'll be men.
Hormone therapy, men could be having uterine transplants and be able to deliver a baby.
That
somehow.
sounds fantastic. I
And
love that idea.
It can't be something that's involuntary. If a guy wants to do that and we have the ability, I am not against that happening.
Wow,
as
if
long as
it's a
it makes it safe.
dystopian future, it's a possibility. The women will take over.
Mhm. Or there could just be baby machines so that women don't have to ever go through pregnancy, you know.
Ideally, I
put
think
in
that
a
would be awesome. Yeah.
in a incubator, and the mom can carry the incubator on her back wherever she goes and put it down when she's at home. Maybe that would be something that happens in the future. I mean, who knows?
Yeah, I
It's
don't know.
fun to talk about.
Maybe we'll just clone people from now on. Something and raise them in literal vats of goo.
Mm-hmm.
Any other questions in the chat, anyone?
Yep, because right now I've been just dealing with
Yeah.
trolls in the chat, you know.
It's
the real trolls, not the
Hey Lou, cut that shit out. We don't need that. Lou's a troll. He usually is a playful troll. I'm not sure what he's saying today because I haven't been paying attention.
It's nothing.
No, this one I've reported a couple had to do some reports and hide from the channel, and there's one I think is just coming back with fake accounts over and over again and going after one person in the chat. So I've been taking care of that.
Yeah. Drag says when he saw the medical bill when his son was born, I guess he passed out and hit the floor.
Yeah, see, again, that's the thing. So people who have babies, the insurance company is going to assume that you have insurance, you have money to spend on that child. So guess what? You're getting billed that extra money. Okay, well, the lactating teaching for your wife. Well, maybe that only costs really $50, but because the insurance company is willing to pay more, we're going to charge $500 for that because we can get away with that to recuperate for the patients who don't have insurance that we have to take care of. That burden is being passed on to you through things like that happening. It's not right, but it's the only way the hospitals can recoup the money they lose for those kind of patients. And trust me, you don't want those patients out on the street dying.
No.
These are the people who have the alcoholism that are running around on the street. I see people like that every day. I take care of at least 2 alcoholic patients every day who are detoxing from alcohol because they were found wandering on the street. You don't want them to get hit by a random car at 3 a.m. because then you've added 3 or 4 more patients who have large medical bills now. So this is a huge service that hospitals and the medical industry provides. They make sure these people at the bottom are being taken care of, but we know that they're not going to pay. We anticipate passing that money on to people who can't pay. And I don't think that's the way that it should be done, but that's the system we have right now. Even with the fixes in the Affordable Care Act, the buck is being passed on the people with insurance. Now that there are more people with insurance, it should be a little more evenly distributed, but we're still paying for it.
Right. And in a similar way, like in Canada, for instance, it is the wealthy that are paying for the healthcare of the people that can't afford it, but it's all done through taxes, right? Like it's similar in that sense because those that can't afford taxes, they're not paying for healthcare. They're not paying taxes. Those that, are making $1 million a year, they're paying higher taxes. So they are making, that it works kind of the same, but you're cutting out that whole insurance aspect in the middle where there's a private sector playing with, values and things. And
it's not to say that there aren't some hospitals that are making serious dollars. There is one here in Cleveland that I may or may not work for, the clinic. Do you know how much money they made last fiscal year?
The hospital itself, like the
hospital system itself.
How much?
$7 billion in profit.
Wow.
After they pay everyone and pay for everything, they made $7 billion. Do you think a healthcare system, a hospital, should be making that much money?
No.
I don't think so. They certainly can't pay me any of that money.
That's insane.
That is insane.
That's literally like a board of directors of just a few people that, or whatever, like the owners.
They're getting very nice bonuses, but I mean, the reason they get the money is there's an unequal billing system. Cleveland Clinic can charge more for an appendectomy than the next hospital. Metro, there's a university hospital, there's several smaller community hospitals. The community hospital can do the same exact surgery, but may get half the amount of money reimbursed for Medicare, Medicaid, because they're not the Cleveland Clinic.
Right.
There's a reputation, and unfortunately, Medicare and Medicaid recognize that reputation, are willing to reimburse them more so than they do other facilities, which isn't fair, but that happens.
The Mayo Clinic in Minnesota is one of those that their reputation is so high up there that their costs are too.
They get to charge more, and Medicare and Medicaid are willing to pay because they think this is, if a patient's going here, they're getting the best care on the planet.
And the thing is that, people sometimes, and even I come in with the expectation that all hospitals are going to be the same. We have Abbott Northwestern, which is a massive hospital, and the closest one to me is a private hospital that I used to work in, and I don't have any records there. I have one in the large hospital system. But some hospitals are not as good as other ones. I've had to bring patients to hospitals that, after I got done there being with a patient for 24 hours after they had been admitted because there was no nurses to handle somebody on life support, I wouldn't bring my dog to a hospital if I had a dog, if I had a dog. I mean, there are quality levels in the care and in how the hospital handles patients and handles staff and stuff that does happen between some of these lower cost hospitals and the higher ones. And it also depends on if they're rural areas, English, it's escaping me, and the large city hospitals, and then the inner city hospitals. So, I mean, there's just so many different things that affect the patient care and how much the patient is paying and how much the insurance is paying.
Yeah, I mean, I've been through, by through family and myself and friends, I've probably been in all of the hospitals in my city in Calgary. There aren't that many hospitals. And a couple of them are older. We actually had one that we blew up a decade ago because it was so old. But they're all pretty much the same. I mean, obviously, some nurses suck, some doctors suck, and then some are fantastic, right? They're just people, right? There's some people are good, some people are bad. But I never really noticed a difference from hospital to hospital other than, it looks older, or it might be a little, nicer architecture or something like that, which is not really a concern when you need medical care. So I do know that we do have obviously just differences between hospitals as well in Canada.
You want to laugh? Our largest hospital in the Minneapolis-St. Paul area has a cave system that's accessible by the staff underneath the hospital. And so some of the hospital equipment, like their water filtration systems for the cardiac unit and for the dialysis unit, are in those caves. Just an FYI.
Yeah, wow. Wow, you guys have a cave system?
Yes.
We just have an above ground water filtration system at our hospital.
Yeah, they just put all those massive filtration machines down in the caves because they were out of the way. It's like, okay, you guys don't have a wine cellar down here too? But this is the same hospital that has a Burger King inside of it as well, which is really just blows me away. And so the patients used to, when I was working there, the patients would come up to the dialysis unit with a Whopper and fries.
Wow.
So, my mother used to work in the ER at Children's Medical Center in Dallas, which was the public pediatric hospital. And in the ER, like I said, they don't charge you for the care you get there. So your kid gets seen, gets taken care of, gets medication, they go home. They don't bill the parents if they say they can't pay. And I can't tell you how many times parents would say, I don't have any money. And as soon as they leave, they would go to the McDonald's in the hospital and buy their kids, kids meal and leave. And it's just like, you said you didn't have any money, but you're going to the McDonald's that's in the hospital and buying something in front of the staff because the McDonald's was right next to the emergency room.
Yes.
Just ridiculous.
Yeah.
Yay, healthcare.
Yeah. I don't know.
So, Shar, you had asked a question I thought might be interesting to address, and maybe
sure.
Christina can give me her feedback as well.
Okay.
How people get paid in the hospital. There's definitely a lot of employees who are hourly, like RNs can be hourly.
Yes.
Some people can be hourly, like staff. There's, staff that cooks, that cleans, that does environmental service, security. Most of those are hourly staff. And then there's physicians, nurse practitioners, physician assistants, and even some nurses who are contracted. And you work X number of days. This is your salary. You see this many patients on average. That can be a physician's contract as well. There can be incentives that say, okay, if you see more than your fair share and you meet this requirement, we'll give you this bonus on top of that. And thirdly, there are also physicians who are paid hourly, and there are also physicians who are basically given like 30-day contracts, like temporary contracts called locum tenens. And these physicians will jump in and out. They'll travel from hospital to hospital, jumping around to fill in for a month when one of the regular doctors is taking the vacation or going to be out for a surgery or something.
Yeah, they did that with me when I was working acute dialysis, which acutes, I'm going with the dialysis machine from room to room or in an in-hospital unit and running dialysis on patients. But for a while, they sent me from the Twin Cities to Duluth, Minnesota, gave me they still gave me hourly, but they reimbursed me for my food, my hotel, my gas, my mileage, everything. I mean, I came out like a bandit. I stayed in this fancy hotel for 3 months. But I mean, I worked my butt off, and I had to deal with the Joint Commission of Health watching me needle stick somebody who was a brand new dialysis patient and violent. And I mean, it was just a trip in 3/4. But yeah, I've been one of those that they had sent to various locations, and there's a lot of money involved, but that poor person, they get thrown into trial by fire more often than not, especially if they haven't been at a hospital and this is their first time working there. It just gets slammed on them without any training,
It could be your first day and you could be expected to work as diligently as someone who's been there for a decade.
Yes. Yeah. I loved it, but oh my word.
Yeah. It can be trialsome because you don't know anyone else who's working with you. You're learning everyone's names. You don't even know where the patient rooms could be. And you're expected to see, 25, 30 patients in a given day. You don't even know where you're going. You don't even know how to put the orders in, where the charts are.
Yep. Another thing that I was going to bring up about the costs in healthcare too is there is a rise in care at home for patients, and this includes patients with long-term problems like needing life support 24/7 and stuff like that. And the cost of the care is about 1/4 of what it would be for this patient to get their treatment or live in the hospital, for the duration per year. And there's various waivers and things that take care of those costs through the counties that patient's in. The only problem that we're running into, I don't know how it is in the hospitals right now, but we have a serious nursing shortage in home care. And so these patients and families are still paying for these services and paying a lot of money for these services, and the patients and families have to do the services themselves because there's no nursing staff. And I was just wondering if that's the same way in the hospitals right now.
Well, yeah, our hospital, there's a lot of turnover when it comes to nurses. There are some nurses who have been there for 30 years, and there's some that have been there for a month. So there's a lot of intermixing between the ages and how long they've been there. But I think that's very common across the medical landscape is that there's always another position that's willing to pay you a little bit more because you have the experience they're looking for. And I don't want to fault anyone for taking that next pay step up. I think that's what we should all be looking for. I mean, you should plan your future around the things you want to do, not the way the system wants to treat you.
Yeah.
But to get on that case of what you're talking about, the home care, we have to train people for that. That's not the same thing as taking care of someone in the hospital. And there's actually the shortage of nurses, I think, can be actually tracked back to the shortage of nurse educators. We are severely lacking in qualified individuals to train the next generation of nurses. And that's partly or majorly due to the fact that nurse educators don't get reimbursed well. You could either make, $80,000, $90,000 being a full-time RN or make $30,000 being an educator. I mean, this is a no-brainer. Which one are you going to choose?
Yeah. And the other thing that is a factor in it too is that the pay per hour is not near as much. I mean, when I was working in the hospital, I was making $45 an hour, I think, as a dialysis RN.
That's not bad.
Now I'm doing 31, which still isn't bad. But
that's definitely on the low end for a dialysis RN.
Yeah, and I mean, I have one patient at a time, and I do night shift, and it's kids.
Mm-hmm.
But yeah, it was a significant pay decrease, and that's why a lot of nurses are not going into the home care part of it, despite the benefit for the patients most of the time, because you have patients that can interact with their community and with their families and be at home and stuff like that. It's a very important part of healthcare. And I think it's kind of being just shoved, public awareness is being shoved under the carpet a little bit as far as the cost benefits and the patient benefits to the home care in general. True. And a lot of nurses are just not heading this direction, unfortunately.
Yeah. It's unfortunate. And I think that's just the market's going to have to correct that. The dollars have to be there for those patients because A, it saves healthcare overall money, and B, it's just better for the patient. Like you said, psychologically, they're in their home rather than in some strange room in a place where they just have 30 different people poking their head in and out. I mean, that's what people need when they're critically ill. But if they're well enough to be at home and be managed, that's what we should be aiming for.
Yeah. Yeah, and there's so much that can be done in home. Like I said, in home, I've done TPN, which is, for anyone who doesn't know, that's nutrition going IV directly into the bloodstream for somebody who can't handle anything in the stomach at all, and it's been long-term. So you're mixing the formulas with fats and things like that to be able to go in. Everything's got to be sterile. I've done that. I mean, there's a lot of things I have done in home, and still, I think, too, from what I've seen with other nursing students that I've had to train over the years and let them follow me around and stuff, is there's still this idea that home care is not real nursing. Yet I'm the only one there. So if something happens, it's on me.
Nursing plus. It's much more responsibility than nursing in the hospital, where the nurse can call me or get me in a minute's notice. The responsibility is tenfold when you're doing the at-home care.
Yeah. And the pay is not near as much. And
the pay should be more. Clearly, it's lagging behind.
And the problem is that the states and the insurance and the government insurances are actually tightening the profit margins on these companies. And so the companies are not giving the staff pay raises, appropriate pay to begin with, because they're operating at a 0.1% profit margin. My friend who's done home care companies for years and is an excellent RN himself closed his doors because he couldn't keep going. And then he'd get patients in that he never got reimbursed for. And he'd have somebody like me come in and do burn dressing changes and things like this in home, and he never got reimbursed for any of the services. So my pay came out of his pocket. And
that's sad.
And there's a lot of companies, but unfortunately, there's also a lot of home care companies that in the last 10 years have been committing fraud. And so that has kind of made the pay push go away from home care, and hospitals are taking over a lot of the home care and keeping a tight rein on it now, because then that's another avenue that the hospital's making more money, and it's getting rid of the market competition, unfortunately.
Yeah, that's a shame. And I mean, the healthcare system is going to undergo a radical change in the next 2-3 decades, because the way that things are running now, it's going to be, a lot of things are being focused as keeping people out of the hospital. Like you said, home care is being heavily implied. The surgeries that people are going through, there aren't going to be people staying in the hospital post-operatively. My hospital is the hospital I'm mainly at. We're already planning for knees and hips to go home immediately after surgery. They're not staying in the hospital anymore.
Yeah. And well, that's why they did my surgery robotic, so I could go home right away.
Mm-hmm. Some of them won't even do the surgeries in the hospital anymore. Some of these surgeries will be done at surgical clinics that are outside the hospital, where there's less risk of hospital acquired infection.
Yep.
It's just a little bit safer option if it can be done that way.
Yeah, and I do think, again, it makes a huge difference for patients. So anybody who watches this later, if you're being faced with, I'm on my home care soapbox here, but if you're being faced with having to have home care options, I mean, there's housekeeping, there's meal prep, there's all sorts of things that can be done in your home to make sure that you are living at home.
Yeah.
And you can get dressing changes, you can get all sorts of things done in home that you could do in the hospital. The only drawback is that you got people coming into your house, and sometimes that ends up becoming an extended family. I've been extended family for a lot of patients over the years.
Yeah, that's nice.
Yeah, but it's for the nursing staff, it becomes something very special. And so that kind of makes the care a lot better in some respects, because
you know the patient, you know the family, you know exactly what their expectations are. Not all of that information gets communicated in an office visit or an ER visit. One of the things that Shar asked about was like the pricing, like how much does an office visit cost? I went over the office visit. You're about $75 to $125 for like a regular family visit, but an observation visit for like when you come to the hospital and they hold you overnight, that usually costs the hospital about $1,000. Insurance companies will never pay more than $500 for an observation.
Yeah.
So every time a patient comes into the hospital just to be watched overnight, that is an automatic loss for the hospital, guaranteed.
Yep.
Wow.
The average hospital bed costs about $1,500 a day.
Yeah.
And an ICU bed can cost anywhere from $5,000 to $10,000 per day.
Yeah. Because you said they were going to do your surgery outpatient, right?
Yeah, and it was only because I had complications, because they had to move my bladder back into place as well.
Yeah.
I was not able to pee. So they had to keep cathing me until I could actually go on my own, because had they sent me home, that's a risk for bladder infections, and then I'm back in the hospital with an infection,
Because I mean, I had my surgery first thing in the morning, and they had no intention of sending me home that day at all, ever.
They were going to send me home within about 4 to 6 hours after the surgery.
Wow, that's fast.
Yeah. And unfortunately, it was the next evening, because then anesthesia scratched my eyeball, and so I had to wait to get the anesthesia doctor to come and take a look at that, and then prescribe the antibiotic ointment so that I could go home. And he had been in surgery all day, so we just, we sat there and waited. So that bill kind of just went up.
Yeah, and that stuff happens all the time too.
Yeah,
yeah. I mean, I get it. I agree. It's definitely good to send a patient home as soon as you can. Like my mother my mother just had her hip replaced, and that's outpatient. Like that's crazy to me, but
I think the concept sounds crazy.
Yeah, but it's good.
But now you have surgeons who have 5,000 hip replacements under their belt.
Yeah,
and they're maybe they're in their 50s and they've done that many. Now for them, that's like riding a bike to work every day. It takes them no excess of effort. It goes very well for 85% of their patients.
Well,
a lot
my
of the
mother
patients are ready to go after surgery. They don't want to be in the hospital anymore.
Yeah, I mean, my mother didn't have. She wasn't under anesthesia for it. She was sedated but awake, like she could feel it the whole surgery, right?
Oh, not me. No, I want to be gone. I was.
Well, so does she, but they don't do it because the recovery is so much longer, right? As soon as you have anesthesia.
Yeah.
It's so they don't do it for hip replacements unless you're really elderly or you have other things going on. They don't do anesthesia, and so the recovery is amazing. Like, I think the thing about going home is just that it's scary, right?
Yeah.
You've got this brand new hip, you're scared. But other than that, it went really well. She recovered super fast. So,
I mean,
see,
after the surgery, all you need is someone to come check up on you. A home care aide can check on you, and if you need to come back to the hospital, you come back.
Yep.
Because everything here in the U.S. is included in one lump payment.
Right.
If you come back, that payment's already, the hospital already has the payment.
Right.
The money's already there.
Yeah.
You don't come back, the hospital makes some money.
My mother had to go back after a week, like for her checkup. And in that time, they just said, call, right? And she did. She called a couple times. She said, there's a little bit of seepage, in the bandage. And they're like, well, is there any blood in it? And she said no. And they're like, oh, well, it's okay. And like, so, she called to ask questions and things like that. But it was, it wasn't bad at all. So.
And we'd much rather have that the patient calls and asks about things, which I know my husband's going to want to thump me on this one, because when I tripped over the cat trying to pill the cat, I didn't call. And, this is, a week and a half after having my surgery. I fell. Yeah, I'm getting thumped. But, again, I know what to look for. I wasn't having any extra pain for a couple days, and that still goes off and on. And I wasn't having any extra bleeding. And what did you just throw at me? I'm getting hit with a pillow. But so it is nice again to have the patient take some initiative in their own care and take part of it, because they are an important part of it. But there's other factors regarding the anesthesia too. Is if you've got somebody with pretty bad PTSD like me, I don't know if they when they did injections into my neck and tried to do a nerve block in my spine, because I've got C1 through C4 damage. They had to sedate me enough just so that they could handle the needles, because I have PTSD very badly.
Then you don't really qualify for that type of a procedure. That's fine. I mean, we need individualized treatments to the patient's needs. You can't just be giving everyone the same thing. That's bad. Yeah.
And so I hope we do start heading more towards a more personalized care system.
And not just personalized, it needs to be genderized as well.
Yes.
We treat men and women equally in a lot of instances where that's not the right thing to do.
Yeah.
Men and women are different. Not in a bad way, but just,
not in a bad way.
Men have different tolerances. The amounts of medications that men should get versus women, they should be a little different because our biology is different.
Yeah. Yeah. And that, you're looking at various medications. You're looking at what hormones they're taking, whether you have somebody who's transgender, whether you have somebody that's in menopause because of hysterectomies, anything like that. There's so many factors in there, and I have seen it happen where stuff has been overlooked, but thankfully, as our health systems are getting more and more computerized and more networked together, those errors are happening less and less from what I've seen on my end.
Yeah, I think one of the funny ones that happens, this happens almost every day to me, when I see patients who are detoxing from alcohol or heroin or whatever, they'll do pregnancy tests on all the women. Even if the women have had a hysterectomy, they'll do a pregnancy test on a 79-year-old woman. I'm just like, why are you ordering this test? This is a waste of money. Granted, it's not a waste of a lot of money. It's still a waste of money.
I saw it happen in one clinic I was in when I was pregnant with my children, where they actually had pregnancy tested a man who had come in for some hormonal issue and some testicular problem. And it's like, why did you give him this test? Unless his testicular problem, oh, good Lord, Dragnot, I'm not showing that.
I did already.
Oh, you did? Okay. Anyway, it's like, I'm sorry, but unless he's got a pregnancy in the testicle, I really don't think pregnancy's an issue with this patient.
Yeah.
So there's stuff that still happens, but then again, that was also over 20 years ago. So, hopefully things are changing for the better. I can't go back and work in the hospitals anymore because I'm allergic to hand sanitizers. My skin will actually sheet off of my hands down to the meat, and things like that. So I'm done with my hospital career, which is sad. I enjoyed it, but hopefully
there are bigger and better things.
Yeah, I've been able to make a big difference, and that's important to me. Now it's looking like I might be stuck with a permanent 30-pound weight restriction, which is probably going to affect my caring for a client that is a young kid, and he's almost as tall as I am. So, lifting is going to be an issue at this point. And I have to be careful because I don't want things to come apart and then I'm back in surgery again.
Yeah, take it easy.
And, then possibly cause myself more damage in the long run. I don't want to do that. My days of swinging 80-pound hay bales for the horses are done, So, yeah. Yes, Dragnot, nipples are fun.
Wow.
Silly people in chat. I love it.
Well, you guys, that was like 2 hours. That was really great.
That was awesome. And
I learned a lot.
Get to the weird woo stuff tonight. We're going to have another hangout for that eventually, I think.
That'd be fun.
Cool.
Yeah. But you guys, anyone watching this later on, there's a GoFundMe that you can help Christina out with her expenses. And if you visit gasp.ca, there's incentives for donating. And you can also buy some of her amazing art and jewelry. So check out.
And I will have the link in the description. It wouldn't let me edit during the stream. So I will edit as soon as this gets processed. So
yeah. And we have some more stuff going on tomorrow. A few more hangouts. 10 a.m. Central, we're going to do some ghost stories live, and it'll be an open hangout. So if you've got ghost stories you want to share, please come. I don't know. I guess it'll be on the Great Debate Gaming channel because no one else has volunteered to do it. And a few other hangouts after that. You can check the schedule at gasp.ca. And right after this, we're going to be playing some video games. And apparently it will involve shots of alcohol. But we do have a limit, so we're not going to be stupid about it.
Yes, make sure that RSC and I don't have to haul people.
Yeah. No, they won't be driving video games, so it's okay.
Okay.
Just shooting.
Just shooting. It's Overwatch tonight, isn't it?
Yeah, we're going to try Overwatch, I think. So everyone's welcome to join. We're all in the Discord if you want to hang out. Yeah, is there anything else?
Start planning for Fallout 76, please. That's what I'm waiting for.
Okay. Okay, that sounds
good. And we're also waiting for Shadowrun from
Cyberpunk 2077.
Oh, yeah.
Cyberpunk.
Thank you, Jordy, and I want to say thank you to everybody who has donated so far. You guys have made a humongous difference, and this whole event has made a huge difference. And we're gonna get through this hurdle regardless, how much we end up getting off the GoFundMe, but it's a temporary hurdle, and I do want to return to work, but I also gotta, make sure that, like yesterday I was in so much pain, and then today I haven't had any, and I haven't taken any pain meds, so it's like one day is better than the other, and round, but it's been kind of a trying month, and this has made all the difference in the world. Just emotionally, this has made all the difference. And
I wish we could do more, but we're doing what we can, and we're going to keep continuing to do what we can, right? So, yeah.
And again, once my thing is done, one of the things that we've been talking about for anybody who is watching this later on is to that we want to continue this for the community. So Troy and I've already been discussing about how for future, if somebody needs help, how we're going to be able to give back. And this is part of the thing that we've been wanting to do as a community. I think it's very important.
Yeah, I'd love that. That'd be cool.
So anyway, I'm going to let you guys go play some Overwatch, and you guys have fun. Thank you, RSC. This was awesome. Thank you, Shar. And I didn't get to say thank you to Holy Spackle yesterday, but she did a fantastic hosting of the Hangout and interviewing and stuff. That was wonderful too. So I just wanted to let everybody know that.
Awesome.
Blessed be everyone. Have a fantastic night, and thank you for everybody who came by and said hello. So
Thanks,
take care.
everyone.
Yep. Bye-bye.
Bye. How do I stop this crazy thing?
The big button. The big button.